Okay, well, hello everyone. I'm David Ergen. I'm the CEO of Asto CT, and I want to welcome you all to this first in a series of webinars sponsored by Asto CT. So these are difficult times, and we're hoping that this type of forum will allow everyone to stay safe and at the same time be productive. Today's webinar will feature interesting standing CT cases from the University of Wisconsin School of Veterinary Medicine. And for this, we have three outstanding clinical panelists. First is Dr. Sabrina Browns. She's a full professor and head of large animal surgery and the large animal hospital at the UW. I've known her for quite a while, and I can definitely say that she's a very big believer in the potential of standing CT technology to care for the hospital's patients. We also have Dr. Diego De Gasperi. He's a clinical instructor in large animal surgery. He's been quite involved in our scanning procedures in the large animal hospital, and therefore can attest to the clinical application of our Equina. And finally, we have Dr. J.R. Lund. She's completing her final year of diagnostic imaging residency here at UW. She's incredibly passionate about imaging horses and always willing to try out new ideas. So I do want to encourage everyone to ask questions. So please use the Q&A tab that's located at the bottom of the screen and type in your question, and our clinical panelists are standing by to answer them in real time. So fire away, they're champing at the bit. So at this point, I will turn the presentation over to Dr. Lund.
Thanks, David. So I just want to thank everyone for attending. I know that these are sort of challenging times with COVID. I'm sure there are people on this call whose lives are being heavily affected by it. So I just hope everyone is staying safe and healthy and their families are safe and healthy. Also want to thank my partners at the UW and Asto for supporting me through the residency, supporting me through this talk. So as David said, my name is J.R. Lund. I'm in my final year of my diagnostic imaging residency, and then I will be staying on at the university when I complete the residency. So it's been my pleasure working with the equine CT from Asto for about 2 years now. And then I do want to just acknowledge that we have a varied group. There's people with lots of different backgrounds here. So some private practitioners, residents, equine specialists, including surgeons and radiologists, people who have a lot more experience reading images than me. But I do hope that everyone finds something enjoyable from this talk. We're really going to focus on standing equine CT of the head and neck, and then cases that we've seen over the past year and a half to 2 years. And then there is another webinar in about 2 weeks where we're going to be focusing on limbs. Okay, so we're going to start out just initially talking a little bit about Asto and the Equina CT. We'll look at some videos, and then we'll move into cases. So it was founded in 2015. It was really the result of a collaboration between the UW-Madison School of Veterinary Medicine and researchers, and really looking at pioneering robotics in combination with helical CT scanning in an effort to safely scan standing horses, doing limbs and heads. The first Equina was commissioned on November 24th, 2018 at the University of Wisconsin. And we have been slowly working on building our database of cases. We're using these cases for teaching, for training, collaboration with other universities and private practices. I will point out that there is a YouTube video link down here. It has a little bit more information on the system, and there are some videos of scanning limbs. So if you're interested in that, feel free to use that link or join us for the webinar focused on limbs. Okay, so here we have some still images of the machine. So on the left, we have the machine in what we would call the limb mode. So basically the skate could be opened up and of course could be walked in either forward or backed in to do hind limbs. They would stand on this pedestal. The gantry would raise up around their limbs and then scan on the way down. Or the gantry can be raised up, rotated 90 degrees, and then put into the head mode for scanning heads. And we'll watch a quick video on that. Just a quick reminder, in this gantry, this is where we're going to have the X-ray tube. We're going to have our detectors, collimators, filters, and then those are going to rotate around as it images the horse. This bore opening is fairly large, so 75 centimeters. We have scanned a variety of patients, from ponies or goats up to large warm bloods or draft horses. We're able to comfortably get both feet in the gantry for scanning, or large heads, so like a draft horse head and neck when we're scanning the head and neck. Again, just a reminder, so you've got that X-ray tube, and then you have your detectors, and then they're going to turn around, creating our image, and that's what creates that field of view. And currently everything inside the gantry is scanned, so that is the field of view. So when we're scanning both limbs, we get the images on both limbs. We're not using a scout, so anyone who's familiar with kind of a traditional CT scanner would often scout first and then scan it. With this machine, we're just scanning everything in the gantry. So the Equina is a multi-detector fan beam CT scanner. It has 24 detector rows. Scanning time is quite fast, so it's at 36 slices per second. There is a variable helical pitch. We are typically using a pretty small pitch, so 0.55, so that is less than 1, but we're still able to scan quite quickly even with that low pitch. It is sealed, although we do attempt to try to keep it as clean as we can. We have a bucket there to try to catch urine if anyone urinates. And then we do some procedures, such as arthrography. So we are scrubbing in there. And so it gets a bit dirty. It's tolerated that well. And then it is quite rugged. So it's designed to tolerate, up to like 1,000-pound strike force. We have had some horses kick it and bang it. Really, there's just been kind of some external scuffs, and that's it. No real damage to the machine itself or issues with scanning after that. We haven't had any horses really blow up during the scanning process, knock on wood. Really, so far, everyone has tolerated it quite well for both limbs and heads. My cat joined me in the last video. I just felt him jump behind me. I'm going to apologize in advance for if the dogs bark. Here is the handle for operating the machine. So you can see, I have a cat here with me. Sorry. You can see the buttons that are used to control it. So there's a calibrate, there's a scan, there's a button to switch it from head to leg mode. There's a toggle, so moving the gantry up, down, backwards, forwards. All right, and here's a video. So here we can see the gantry moving up and down. And so this is how it would scan the limb. So it would move up to the desired level and then scan on the way down. And now we will see it move up to head mode. So once it's up to this level, at this point, some pins would be removed. The gantry is rotated 90 degrees. Pins are replaced on the side. And then we can move it up, down, forward, and backwards, so it can accommodate different heights of animals. And then back down into leg mode. Okay, so that was just a quick video on how the machine moves. So to touch on patient prep. So we do work with a variety of clinicians, so our general surgeons, our internal medicine folk. So there's a little bit of variability with the sedation plan, and it's always tailored to the patient. But I would say in general, these horses are receiving ace-promazine, either IM or IV, in their stall. And then kind of once they settle down in the stall, they're brought out into the hallway where they usually receive IV detomidine. And then either in the hallway or in the room where the CT machine is, we finish prepping them. So we put cotton in everybody's ears. The machine is quite quiet, but we still put cotton in there to reduce them from startling. Everyone gets blinders on, and then we do tape their ears down if we're doing a head or a neck scan. So we saw that the gantry is relatively large, but we don't want their little ears to touch it and startle. So we tape them down. Everyone has been tolerating that quite well. And then for some horses, we'll dim the lights. I think with that dark gantry sort of moving across their head in the light, bright room, it can cause them to startle just a little bit and bobble their head. So dimming the lights we found to be helpful. All right, so here we can just see some other views of the stocks. So here are our stocks and the gantry. This headstand and gantry are adjustable. So again, for a pony or a larger horse, we can just move it up and down. We do have these pads in our stocks, and we found that it narrows it a little bit, and some horses really do better if they can lean up against it just a little bit. It helps stabilize them. At the front of these stocks, we have a stall guard, so something a little softer that they can lean forward into. So if we're trying to get caudal on the neck, that's helpful to really be able to push the gantry up close to their bodies. Okay, and so here we have a video of the gantry moving across that head platform. And so we've tried a variety of different pads just to try to straighten their heads as we scan them. So here's a patient that was scanned. You can probably hear in the background a little bit of noise, and that's just the sound of the machine, so quite quiet. Here we are moving the gantry across the head and the neck. This horse does very well. At this point, we could pause the gantry or move it back over the head and neck if the horse needed to be resedated or wasn't tolerating it. Then once we've moved it back as caudally as we want to for scanning purposes, all the people in the rooms decide, okay, now's the time to scan. Scanning begins, and the gantry moves cranially as it scans. There is a bit of space at the edge of this gantry where scanning doesn't occur. So as the gantry is getting close to the horse's nose, if you were to move at that point, the scanning is done. So it wouldn't affect the image. We've calculated it out. I think the majority of horses, I think our average is about 1.4 to 1.6 scans. So typically we're doing 1 to 2 scans. I will say right now we're quite critical of those scans. So if there is, say a little movement here, but we're really interested in a different area, we typically will just scan them again if they're standing well, just to make sure we have all the information we want. So that number of scans is a little bit of a fuzzy number. This is the horse's perspective. It is time lapse, so it is a little chunky, but you saw how smooth it was in the other videos. But you can see how having that dark gantry and then the light room may just cause them to wake up a little bit when they're sedated, so dimming the lights is helpful. And then typically, the horse would have the lead line up here, and then a person would be standing here, oftentimes behind this lead for protection. And then once the scanning is done, we go over to the viewing station that's in the CT room, and we review the images. And at this point, we're really just looking to make sure we have the area of interest in the scan and checking for movement. And then, like I said, if we want to rescan, right away, if there's a touch of movement or something we don't like, we want to reposition, we would rescan. Then once we're happy with the images, the horse goes back to his stall to recover. These images get kicked over to our PACS system, and we go to our traditional viewing location to review the images. Okay, and lastly, before we start looking at cases, just to touch on radiation safety. So this machine does have a very low leakage of radiation, so it's designed largely off of the technology for the CTs that scan luggage. So as you go through the airport, through TSA, and they're scanning everyone's luggage, and you have an individual standing next to that machine all day long reading images, and then you have the general public walking by the machine. It's quite safe. And so this machine, being designed largely on that technology, is also quite safe. So you can see the KBP and the MA, the low MA that is being used. So we do have people in the room when we are scanning. We minimize the number of people, but there's a person holding the horse, there's a person performing the scan. Oftentimes we have another individual here, someone may be ready to put their hand on the horse if needed. And then, like I said, the horses really have tolerated the scans quite well. Everyone in the room wears their gowns, and then we do have shields that people can stand behind. Okay, so if there aren't any questions that I need to pause for, we will move on to cases. Great. So this first case is quite near and dear to my heart. This was a personal horse of mine. This is Oliver. And I'd acquired him through sort of a series of circumstances. A friend of mine was his veterinarian, and he had an incompletely excised squamous cell carcinoma on his left third eyelid. And so we treated it with cisplatin and further surgery. He ended up having the eye enucleated. He had some ulcers and some issues with it. But overall, he was doing quite well. He was rideable, he was comfortable. Externally, everything looked very good. And then last winter, in the middle of our polar vortex, so those of you who remember it, it was -30, -40 degrees Fahrenheit and kind of ice everywhere. He went acutely blind and ataxic, unfortunately. So we started treating him medically, gave him some steroids, kind of addressed the ataxia, and we were able to haul him into the university. He trailered quite well. He did well at the university, and we were able to scan him safely. So I know that we said for most horses, we sedate them with acepromazine and ditomidine. For him, with the neurologic issues, we did just use just a little bit of xylazine, and he did very well. And here you can see his little hood is on backwards. He is blind, so he didn't need it. So we were just using it here to hold his ears down against his neck. Oh, you can also see, this was before we were using stocks, and they still often stood quite well. So there's a gate right here, there's a headrest here, and then that was adjustable also. All right, so here's the scan of Oliver. So we're starting rostrally and moving caudally. This is going to be the left side. And so remember, he had the enucleation and the squamous cell carcinoma on his left side. So here we are moving through the cheek teeth, through the sinuses. So here's going to be where that left orbit should be. And then if you focus in this area, you're going to see a large soft tissue mass that invades the ethmoid turbinates, the surrounding sinuses. There's extensive lysis through the calvarium, extension of the mass into the calvarium, sphenopalatine sinus. So here we can just see some still images. So there we are at the level of the ethmoid turbinates, sphenopalatine sinus, and again, that large amount of lysis through the calvarium, some expansile lysis. So, seeing these images, it was very easy to know that the right decision was to humanely euthanize him. If he hadn't been my own horse, I would have been reluctant to believe that he had done as well as he had. Looking at these images, just an extensive amount of disease and extension into the brain. So it's sort of amazing that he did as well as he did. We did not do histopathology. The working theory is that that's the squamous cell carcinoma. I have thrown in just a handful of papers. I know we have some residents online who are all busy prepping for boards. So this one is just CT appearance of equine sinonasal neoplasia. And so they looked at 15 different tumors. And then for 10 of the horses, they had radiographs to compare to the CT. And so I find it interesting that in all of the radiographs, they could see the mass, so that's great. If it was in the caudal or the rostral maxillary sinus, they typically could identify that correctly. But if we're looking in other areas, so the sphenopalatine sinus, none of the masses of the 5 horses where there was a mass, was it identified on the radiograph? It was only seen on the CT. Again, if there was extension into the cranium, it wasn't identified on radiographs. And then in only one of the horses was a mass in the retrobulbar space identified on radiographs compared to CT. And then they also reported that radiographs do really underestimate features of malignancy. So severe osteolysis or osseous production are going to be underestimated. While I wish we had radiographs of Oliver to kind of show the difference, I think this paper is interesting when thinking about his case. Okay, here we have Bob. Bob is an older pony, 28-year-old Hackney pony. He's kind of the opposite of Oliver. So this is a dorsal multiplanar reconstruction of him, and I'll run through that video. So Bob presented with orbital disease. He had kind of a soft tissue mass around the caudal aspect of his eye, some exophthalmia. So here we can see when comparing the 2 orbits, we've got that exophthalmia. And then along the caudal aspect, hopefully you can see there is sort of an oval soft tissue mass. You may be able to appreciate that better when it's not moving. So over here compared to the normal side. So given his age, given the appearance, the initial concern really was for squamous cell carcinoma, which is part of the reason this CT was done. We did ultrasound him and do an FNA on that mass, and it ended up being an abscess and cultured strep zooepidemicus. So he was treated medically, did quite well with that. Unfortunately, he's this older Cushingoid pony. He had some corneal ulcers. So while the abscess responded quite well to the medical therapy, the corneal ulcers kind of went in the opposite direction. So he did end up developing a desmetocele, and unfortunately they had to enucleate that eye, but all of the periorbital swelling had resolved. And then he did well after that. So this is a 1.5-year-old standardbred. This was an Amish-owned filly who was going to be used as a cart horse. And she presented for increased respiratory rate and effort. I'll let this play through and we can talk about what we found. So at the level of the common nasal meatus, extending from the nasal septum and then continuing along to the vomer, there was a thin membrane. And this membrane basically obstructed the right nasal passages and sinuses from the trachea. So there we can see that membrane. I'm going to play it one more time so you can kind of watch it come through. So if you watch over here. And then on the opposite side, her left side, there was a lot of mucosal thickening. So thickening of the ventral concha, the conchal bulla, the ventral aspect of the left ventral conchal sinus, the nasal meatus. And then she's a young horse, so she does have that normal juvenile dentition. So she was diagnosed with a congenital unilateral right-sided choanal atresia, and then likely a secondary rhinitis and sinusitis on the left-hand side. So this was due to a failure of that bucconasal membrane to rupture during development. So options were discussed with these owners, including surgery to go through that membrane. And for a variety of reasons, they elected to actually do a permanent tracheostomy on her. It was done as a standing procedure. She did well, and she has done well afterwards. Okay, here's another young horse. This is a 2-year-old Icelandic horse who presented with a known dentigerous cyst. So this horse had had a draining tract by its left ear for maybe a year or so. The veterinarian had taken radiographs on the farm. Oops, back up, sorry. And so we can see this tooth-like structure at the base of the left ear. So she came into the UW for further imaging and possible treatment. Here we can see the axial images, and I'll pause that for you. Point out a couple features. There we go. So there's that, those tooth-like structures. There were two of them. And then interestingly, so along the calvarium, we have thinning and then loss of bone. And extension up to the cerebrum. And then these tooth-like structures are also intimately associated with the TMJ. So I'll scroll through there. There was a bit of a concern on how she would do surgery, given this loss of bone and the association with the TMJ. And these owners did elect to humanely euthanize her. Over here we have, this isn't an image we would use for diagnosing really, but it's interesting, I think, for owners sometimes to look at these images in different planes. So rotating through the skull, again, you can see that tooth-like structure. So here are the gross images. And then just like we saw on the CT, there is loss of the calvarium at the level of that tooth-like structure. And then this was just a fibrous membrane. Okay, so this is a 20-year-old paint gelding, and he presented for a 6-day history of left-sided epistaxis. So this is a sagittal image. This is the left side. This is the right side. Down here is rostral. There's the calvarium, ethmoid turbinates. Calvarium, ethmoid turbinates. So we can see this large soft tissue mass that extends through the frontal sinuses, dorsal conchal sinuses, other surrounding sinuses, and it was closely associated with those ethmoid turbinates, and you can see some extension into the ethmoid turbinates. It's an axial image, so you can see that mass. And then what I'd like to point out is you can see sort of this hyperdense swirling or hyperattenuation, swirling in there. You can see it a bit better when you move it more towards a narrower window or a soft tissue window. I apologize for not including that video, but hopefully you can appreciate it. And then this is just a still image. So based on those characteristics, the most likely differential was an ethmoid hematoma. This horse did go to surgery, and they removed it, and the mass was sent off for histopathology, and it did confirm that it was an ethmoid hematoma. It's a similar case. So 16-year-old saddlebred. He presented with a history of nasal discharge, intermittent epistaxis. So again, we had similar characteristics. We have sort of a large mass, now right-sided, with a swirling appearance, and soft tissue to fluid attenuating material within the surrounding sinuses. At the time of surgery, that material was quite purulent. And this was confirmed to be an ethmoid hematoma. Here's another little paper. So this one was from JAVMA 2012. So they looked at CT in horses that had ethmoid hematomas. They had 16 cases. And then quite interestingly, they found that in the majority of these cases, so 10 out of the 16 horses, it had kind of this hyperdense, hyperattenuating, swirling appearance. So this is a wide window, a window that's better for looking at bony structures. This is a narrower window, so better for looking at soft tissue structures. And so you can appreciate it in both windows, but more so in this soft tissue window. With this machine, they did have a scout image. So here we can see the level that we are on the horse's head. So they had radiographs on these horses too. And in almost all of them, 15 out of the 16, they did identify a mass on radiographs. But in 5 patients, the anatomic localization of the mass was incorrect. All of the horses included in the study did have paranasal sinus involvement. 2 of the horses, this was not identified prior to CT. And then in 5 of the horses, the sinuses were incompletely identified with radiographs alone. So I think it just speaks to the usefulness of being able to CT these horses beforehand, before sending them off to surgery, and just getting a nice global picture of what's going on. This is an 18-year-old quarter horse. And this mare had recently developed some head shaking, and then she had some intermittent nasal mucoidal discharge. So dorsal multiplanar reconstruction, rostrals down here. There's some still images, so sagittal, mid-transverse. So we can see this very round, very well demarcated mass that is closely associated with ethmoid turbinate. So I'll play through that again. So you can see right here, and it does look like there's either extension to or maybe some confluent fluid along those ethmoid turbinates. And then she had some fluid in her caudal maxillary sinus also. So based on the characteristics of this mass, the most likely differential was just a nasal cyst. So yes, it was closely associated with the ethmoid turbinates, but the other characteristics, we thought it was more likely a cyst. Still could be an ethmoid hematoma. She did also go to surgery. She had a frontonasal bone flap, and she did have a sinus cyst that was removed in its entirety. And she did quite well. She did actually end up getting a little bit of facial suture periostitis, so we saw her a few weeks later for that, but otherwise has been doing well. One of our last papers here, so quite recent, so from EVJ 2020, they looked at the CT characteristics of equine paranasal sinus cysts. So interestingly enough, they saw this kind of hyperattenuating wall-like structure around the cyst, and this is pre-contrast. So they saw this in the majority of the paranasal sinus cysts that they looked at. They did not see that hyperattenuating swirling appearance that we saw with the ethmoid hematomas. And then the other thing I found quite interesting with this paper was when they looked at the Houndfield units of the material within this cyst, I think our assumption would be that it would be, pretty close to fluid. They're often a fluid-filled cyst, and so maybe that would help differentiate from other paranasal sinus diseases. And unfortunately, it didn't. So these cysts often have this kind of hyper-attenuating, thin, mineralized structure around them. Do not have a swirling appearance, and then again, unfortunately, it's challenging to tell with Houndfield units that is a cyst. Okay, one more mass, and then we'll switch gears over to TMJs. This is a 7-year-old quarter horse gelding. He presented, actually he was referred in for the CT. This mass, you can see right here, this small round mineral attenuating, a kind of heterogeneous mass was diagnosed with radiographs, but they were discussing options for surgery, and so they wanted the CT for surgical planning. And he does have some other dental disease that you may notice there on those images. I just spoke to his veterinarian this morning, and the owner's actually elected to not pursue surgery at this time. They are going to just continue to monitor it, so I don't know exactly what it is. Our assumption is some sort of odontogenic mass, so something like an odontoma or a cementoma. It could be something like a chronic mineralized hematoma, or a chronic granuloma. And they're just going to monitor, they're going to re-image this horse and see if it's growing, and then make decisions as they need to. Okay, so quick pause. Anything I need to address? Otherwise, we'll move into TMJs. Looks like we're good. Okay, so this is an 18-year-old Tennessee Walker who, as you can see, presented for really severe advanced osteoarthritis of the TMJs bilaterally. I'm going to show a quick video. So she was eating on the farm. She was doing okay. She did have swelling at the level of the TMJs that was seen by the veterinarian, and radiographs were taken on the farm. They could definitely see she had this advanced osteoarthritis of her TMJs, but the owners did want to pursue advanced imaging options and discuss perhaps surgical treatment. So we did end up scanning her. It was agreed, due to the severity of this disease, that a condylectomy was not in her best interest, and so she went back to the farm. They're just keeping her comfortable. But you can see just the tremendous amount of osseous proliferation around both of those joints bilaterally, and then fragmentation, rounded osseous foci throughout there. Okay, so this is a 10-year-old quarter horse, and he had recently begun shaking his head, and he would mostly shake it to the right side. So this is going to be the right side of the image. So you can see his TMJ is going to be here. So he was looked at by an equine dentist. They were initially concerned perhaps for some dental issues, and he had some, but nothing that would really explain his head shaking. That veterinarian noticed that he had an enlargement of that TMJ and took radiographs and saw some changes, and that's when he was referred to us for further imaging. So you can see, hopefully, in that TMJ joint, that mandibular condyle, it is quite sclerotic, and the margin is fairly irregular. And then we do have these osseous cyst-like lesions throughout it. And in the zygomatic process of the temporal bone. And there are some changes on the left side also. There is another cyst in that left mandibular condyle. The 3D reconstruction, so this is the right side, the very abnormal side. We'll look at the left side. Let's slow that down for you. All right, so here we can see, again, our right side, that's much more affected. So the irregular margins to the joint and some osseous proliferation around there. They did just inject this TMJ about a week ago, and they're waiting to hear back from the owners to see if it helps this horse. Okay, one more TMJ. So this horse, this little 5-year-old paint gelding, had this really sort of long, strange history. We ended up CTing her. I'll show you the findings. The findings don't actually explain the full history, but they are interesting from an imaging perspective. So she last spring, so spring of 2019, had just some mild neurologic issues. So she couldn't buckle her left carpus when she was walking downhill. And then she began tripping a little bit more. Then she had some episodes where she became quite stiff and was sweating. She had some episodes where she became recumbent and needed assistance to rise. She had issues with dysphagia. She was a horse that always had kind of a straight, low head carriage. The owners felt that she was, more stiff now. She had a very full workup, a CSF tap, cytology. We're checking for all the infectious diseases, which were negative. She had a radiographic myelogram performed. There were some changes to the articular facets. but nothing that would really explain her clinical signs. So we ended up CTing her head. I'll run that through. So on her right side, she had a large amount of osseous proliferation of the temporal hyoid articulation and then the surrounding structures. And she did have a cortical discontinuity there, so a pathologic fracture through that proximal stylohyoid bone. So we're looking up in this region. Apologize if that's small on your screen. But here again, we're comparing our abnormal side to our more normal side. And so again, this doesn't explain everything that's going on with her. Perhaps it does explain some of the dysphagia, but it is interesting, such a young horse, that she had those changes. And then, as I said, she had some changes to her TMJ also, so we can see sclerosis on these mandibular condyles, a bit of an irregular margin, an osseous cyst-like lesion, and they were abnormal bilaterally. So again, not really explaining her full story, but interesting from an imaging perspective. Okay, so I'm going to take a quick pause, make sure there's nothing we need to touch on. I'm going to take a break for just a minute from cases, and we're going to talk about the soft tissue window. I know there's been a number of questions, people interested in more of a soft tissue window with this machine. So all of the images that we have looked at so far were performed on standing horses with an unfiltered image, which is quite good for looking at bone or osseous structures. More recently, we've just started using a medium frequency algorithm to highlight soft tissue structures and to be able to look at things in more of a soft tissue window. I'll share some of those images with you. You can see this window is not as good for looking at the detail of the bone, but we do see better contrast within the soft tissues. And so here we can see in these top two images, these are sort of our two different options right now for looking at soft tissue. And this is that unfiltered image that we've been looking at that is quite good for looking at bone. And then what I did here is I windowed and leveled. I took this image and I windowed and leveled it into a soft tissue window. So you can see our window width and our window level here. It's very similar to what we have up here. And you can see that the quality of the image for looking at soft tissue is much better with those medium frequency algorithms. So we're quite excited at the University of Wisconsin to be able to start using that with this machine in both of our heads and then our limb cases. And then we'll be using some more contrast here in the near future, and now that we have access to these soft tissue windows. Let's run through a video of one of those. So this is just a teaching horse. She was scanned just so we could look at the soft tissue window. She was not a clinical case. There's a little bit of motion in there. But again, you can see the improved contrast within the soft tissue, you know, in the periorbital region, looking at the fat and the soft tissue, you can just see that much better, much clearer. So that's an exciting step for us. Right, this was a older mare, 25-year-old mare. She came in from the field with a wound on the left side of her head. There was exposed bone. So here is a video of her CT. So she ended up having a comminuted fracture of her left zygomatic process of the temporal bone and then the coronoid process of the mandible, and extension into the TMJ joint on that side. So let me pause this for you. So here we can see our affected side compared to the unaffected side. You can see that cortical discontinuity. There are gas opacities within the soft tissue. That's an articular fracture. We made some different 3D reconstructions, you know, not that we would use these for kind of a diagnosis purpose, but I think they can be helpful for explaining things to clients or sometimes for surgeons to get a better 3D look at what is going on. I like this image over here. So here we can see that fractured coronoid process. Due to her age, other underlying health conditions, and that joint was septic at the time we saw her, the owners did elect to humanely euthanize her. Okay, we're going to look at just a few dental cases here, and then we will look at some necks. This is a 13-year-old Belgian who had about a 2-month history of nasal discharge. The veterinarian had seen the horse on the farm about 2 months prior to us. The horse had had halitosis at that point. The veterinarian was basically able to pluck out this portion of the palatal crown on the 208. And then for a series of reasons, we didn't see the horse for about 2 months. I did leave this part in here for you because I just wanted to remind our, sorry, I'm getting a text message, the beauty of lecturing from home. I just wanted to leave this in to remind me to tell you that, so when we're looking at these dental cases, you know, it's great having the CT. You know, one, we don't have all the superimposition that we would with radiographs, but also we can use these reconstructions to sort of change the angle that we're looking at every tooth. You know, so those teeth sit in there in the mandible and the maxilla at slightly different angles. And so with the CT, we're able to really appropriately look at every single tooth. At the University of Wisconsin, we are quite fortunate to work with some great equine dentists. So we do CT a lot of these cases. So this horse did have that tooth extracted. They did a minimal buccotomy and the horse did quite well. This is an interesting case, and I don't have all the answers on this one for you, but it's a 14-year-old Percheron who had known severe dental disease. So you can see this very severe shear mouth. We've got some absent teeth. The owners were doing a great job of keeping this horse up. It was a big horse. They kept weight on him, even with these dental issues. He also had a history of many years prior having a mandibular fracture. So he came in for some nasal discharge and continued dental management. And you can see here that bilaterally he has these really expansile lesions in both of the mandibles. Over here we've got the smooth osseous proliferation. And then here on the left side, we can see that there's this cortical discontinuity that would be suggestive of a draining tract. This horse didn't have a history of a draining tract. There wasn't one present at the time of presentation. So the teeth were addressed, the horse was floated, some extractions were performed. It was discussed with the owner of, you know, perhaps doing an FNA on these mandibles to get a better idea of what was happening. And it was declined at that time. The owner was going to monitor it and perhaps bring him back. So I'm not exactly sure what's going on with them. I've talked to a number of different people. It's an interesting case. You know, is this associated with the historic fracture? Is this something like a, you know, a neoplasia and aneurysmal bone cyst? I don't know. I'd love to hear other people's thoughts on it. This horse did also have some small presumed nasal cysts, so very well demarcated round structures that it was assumed was causing some of that nasal discharge. And again, the owner was just going to monitor those. A couple more dental cases. So we've had a few of these now. So this horse, an 18-year-old thoroughbred who had a chronic draining tract. You can see they took radiographs and you can see the lytic region surrounding this osseous sequestrum there. And then here's the CT. So the CT, we can see it's much more extensive than we would have thought with those radiographs. And over here, you can hopefully see just how extensive that is. So the decision was made to surgically debride that region and treat her aggressively with antibiotics for a month prior to extracting any teeth. There was a bit of a concern for perhaps causing a pathologic fracture. So I have a dorsal multiplanar reconstruction here. This is from the same day as the images we just saw. And then we rescanned her a month later. So we'll look at those two. There you can see all that smooth osseous proliferation on the lateral aspect of the mandible, and then there's that draining tract and that bony sequestrum moving down. They're quite impressive. And then here we are a month later. We still have a fair bit of kind of smooth osseous proliferation. And here's that track. And you can see really almost all of that bony sequestrum has resolved at this time. And they did go ahead and extract the 406 orally. And she's doing well. Similar case. So again, this horse had a long-standing chronic draining tract. So here we can see on radiographs, there we have a surgical instrument inserted into the draining tract. And doing a mean intensity projection images over here, we can see again just a really extensive region of lysis with a presumed bony sequestrum in there, extending all the way down through the mandible to where that draining tract was. So they did a similar course, debrided, antibiotics, and then she came back, I think, about a month later for some extractions. Okay, we've got just a few head and neck cases. I think we are doing okay on time here still. So this is a standing horse, a standing sedation. And so here we are at C1, C2, C3, C4. So the majority of C4 in a standing horse is where we have been able to get. And then this is from a horse that had been euthanized. And then we scanned her because we just wanted to be able to kind of rotate the horse around, do some dorsal recumbency, lateral recumbency in preparation for doing horses under general anesthesia. And so here we are at C1, C2, C3, C4, C5, the rostral aspect or the cranial aspect of C6. So there's some changes that are going to be made to the gantry, hopefully with beveling it out, which will allow the gantry to move a bit more caudally over the neck. So hopefully we're able to get down more caudally. We do know that there's oftentimes pathology in that region we would like to see. But you know, even just being able to CT this level in a standing horse has been quite useful. This is a 14-year-old Appaloosa. He had a history of about 6 years prior, some known neck trauma, but he had never been ataxic or had any swelling in that region. He came in from the pasture one day with swelling over the C2 to C4 area, and he'd been known to roughhouse with his pasture mates. Radiographs were taken on the farm and a diagnosis wasn't made at that time. The owners were debating doing CT. A couple days went by. The horse declined a bit, came into the UW, and originally we wanted to do a standing CT on him. We were hopeful we would be able to get to that region standing, but due to the progression of the clinical signs, we ended up scanning him under general anesthesia. And so here we can see that we have a C2, C3 subluxation. There were some osseous fragments in the area, and then some moderate to severe compression of the spinal cord, explaining this horse's clinical signs. So due to the prognosis, these owners did elect to humanely euthanize. Here you can see that setup. So it's a surgery table, and then it can be moved closely to the gantry. And just I think a couple more cases and we'll be wrapping up. This is an older 24-year-old Dutch warm blood. We were scanning this horse for just a day. We were practicing moving down the neck on different size, different shaped horses. This horse did have a known history of a nuchal ligament bursitis. He had been injected in that region with steroids a few times and then was treated with shockwave therapy also. So again, rostral is here, the horse's head would be here. So we're looking at the cranial aspect of the cervical spinal column. And we can see that we have mineralization in the region of the nuchal ligament, the bursa, caudal to the occipital protuberance, so some desmopathy in that region. So it's sort of an interesting case that we found. This is an 18-year-old Arabian gelding. And he had a very long-standing chronic cranial nuchal bursitis. So it was originally diagnosed in 2013. They've been treated medically and surgically, surgical debridement. These radiographs and this fistulogram were performed of January 2019. So here we can see that catheter with contrast in it, and then that contrast extending to the caudal aspect of the occipital bone. Surgical debridement was performed. Horse was doing pretty well, and then the owners noticed a draining tract kind of starting to reform, and so at that point they elected to CT this horse. There is a catheter with contrast in the fistula, which you'll see here momentarily. I can roll over here. So this is cerebrum, this is cerebellum, spinal cord, C1, C2. There should be occipital bone here. So we can see that there's just been a severe amount of lysis from osteomyelitis and that chronic draining tract. Here we can see that catheter with contrast coming frighteningly close to the caudal aspect of the cerebellum. This horse did do well after this procedure. These owners did elect to not treat the horse any further, keep him comfortable, and I do believe he's been humanely euthanized now. See this in here, we haven't done any clinical cases yet, but we are kind of starting to play around with it. I know some other institutions do a fair number of CT myelography. I think it's quite interesting, quite useful in horses. We hope to be able to do some more in the future. So this is that horse that we just looked at. And then I threw these images in here. This is forelimbs of a horse that we did a venogram on one of the limbs. So like I said, we are doing a webinar in about 2 weeks for focus more on limbs. So we'll review again how the machine works and then talk through a number of cases on limbs. So I really appreciate everybody for joining us and for listening. I hope that you found it interesting on some level. Appreciate you taking the time to join us. And again, hope everyone is staying healthy and safe. Here's that information on the webinar. Here's the link. I would recommend registering tomorrow. So the link is up right now. It's been a touch glitchy today. It's going to get sorted out. So I think just to be on the safe side, if you can remember to do it tomorrow instead of today, that would be great. And then I have included my email address. I'm always happy to chat with people, answer any questions I can, or get you connected with a person who could answer questions for you or collaborate on cases or research.
There's a question about IV contrast in standing patients. Have we used it, and what's our experience with that?
Yeah, so have we used IV contrast in standing patients? So we have done just a little bit with heads because we just got the soft tissue window. It just wasn't working great with that unfiltered image. So we're going to see the contrast a lot better now that we have access to that soft tissue window. So we'll be doing more in heads. We have done some in limbs. And to be honest, we haven't done that many clinical cases. I've done a fair number of venograms in horses. We're looking at kind of normal issues that we're going to see in these standing horses. Arthrography we've done in some standing horses. We've used contrast for looking at some suspensory lesions. So I think now that we have that soft tissue window in, the number of cases that we will use contrast in is going to exponentially increase.
Again, thank you, JR, for the presentation, and thank everyone for participating. And we look forward to having you on for our next session, our next webinar session. So thank you, everyone.